Hi, my name's Hannah and I'm going to be showing you today how to do skin sampling on dermatofomites, bacteria, and histopathology. I will start with the dermatofomites. So I'll just show you what's on my tray. I will have gloves, sterile adson forceps, a DTM or a transport medium, alcohol, 70%, and my Woods lamp. If a patient were to present with these signs and come back positive, some of the treatments could include itraconazole or griseofulvin, but be careful as some drugs have low margins of safety. So to begin, there are two different types of dermatofomites, known as trichophyton and Microsporum canis or Microsporum giuseppe. Some ways you can contract this are through direct contact or through fomites, also seen on water bowls and toys that are shared between pets. This is normally seen in cats versus dogs. It's more common in cats. And you can see this through alopeciated lesions with broken hairs, and you can, if it progresses further on, you can see some redness, you can see more alopecia with irregular margins or circular lesions. It will become very itchy as well. So if I were to look for a positive case, I would start with my Woods lamp. So I would make sure that my lights are all turned off. I would put my gloves on, as I do not want to contract this. And I would then take my Woods lamp and place it around the lesion that I think is the most periphery. And then I would turn it on. And a positive would glow green, or it could glow yellow-green. However, some strains of the Microsporum do not fluoresce whatsoever, and some bacteria do fluoresce. So that's why it's very important to do the culture as well. So with the culture, it's known as a DTM or dermatofomite transport medium. It contains sabroid dextrose agar along with a phenol red pH indicator. So if I were to get a positive with the Woods lamp, which I would look at also under a microscope to see if I see any of the Microsporum or trichophyton, I would then take this alcohol, place it all around the periphery of the lesion as it kills the bacteria. And I would then take my gloves, where I would still have my gloves on, but if I were to take them off, I would make sure that they were on. And I would then take my sterile adson forceps, pluck hairs from the area, and then place them into the DTM. I would then twist the cap on, but not all the way, so that way the fungus can still grow. What's cool about the DTM is that it has an antibacterial and an antifungal agent in it, so just the dermatofomites grow in there, which is very cool. And I would start to see some growth after 48 hours, and the phenol red would turn from amber to more of a red color, and after 7 to 14 days, the amber will become a more red color, and there will be white fluffy colonies growing. And that is it for the dermatofomites. So next I'm going to move to my bacteria. So after this, if the main concern for this, the indication for this is persistent purulent pyoderma. So if my patient were to come in with this, I would take my sterile swabs, my cover slip and slide, or a transport medium. And then I have my lighter for a heat fix. So I would then take my swabs out while wearing my gloves. I would take them out sterilely, and I would swab the area. I would then roll it onto the slide, and then I would heat fix it. Stain it, and then place my cover slip on and look at it under 100 power. And I should see like some gram-positive, or I could also see gram-negative bacteria as well. If it were gram-positive, it would turn purple, and some gram-positive bacteria are Staph aureus and Streptococcus. Some gram-negative bacteria that I could possibly see, especially around the ears, is Pseudomonas and Proteus. If I didn't want to do this as well, I could also take my sterile indicator and put it in the transport medium, and then send it off for another lab. And then next, I have my histopathology. So with this, I have my clippers to clip an area if necessary, but I would clip it very gently. Scissors, my forceps, my local anesthetic, usually lidocaine with epinephrine, my pen just to write down and label the patient, my 10% formalin, my disposable biopsy punch, my instrument pack, and my suture pack. So to start with this, I would first off clip around the area if necessary, as sometimes there's a little bit too much hair for it. And I would then take my biopsy punch. Oh no, sorry, I would take my local anesthetic and I would inject it if needed as well. Wait a few minutes for that to work. Then I will take my disposable biopsy punch, which is usually in a sterile package as well, not just like this. And I would then press in and twist around. And then I would take my sterile scissors, still holding on to the biopsy punch, and clip it off. And I would then put it into my 10% formalin, and I would do 2 to 3 of these punches. Afterward, I would take my suture pack, and I would suture up the area and perform a cruciate suture pattern, and I can take that out within 10 to 14 days. And then afterward, I can write down the patient, where I took the area, what area I took it from, and what the date is, and all of that other signalment and history. So the main indications for doing a histopathology is for neoplasia, immune-mediated diseases, and any other dermatological condition that is not improving with conversional therapy. So thank you for listening to my skin sampling techniques of all 3. Afterward, I would be sure to clean up all of my equipment, write in the patient's files. If they're all different patients, I will write in all of their files, and just to see if there's, and I will let the doctor know about my findings. I will send this off properly, and I will also send this off properly if I was sending it away, but I can keep that in store at room temperature. And if I were to send my bacterial sample away, I would also send that away properly as well. So thank you for listening.